Hi guys, welcome back to the channel. This is the second trial, ELAIN follow-up, long-term clinical outcomes after the early initiation of RRT in critical ill patient with AKI. My name is Dr. Buddhabhushan Borade. You can follow me on Instagram on Meditalk by Dr. Bhushan or YouTube Meditalk by Dr. Bhushan. You can subscribe to my channel.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in adult critical patient with acute kidney injury, does early initiation of early replacement therapy compared to the delay initiation of RRT reduce the composite endpoint of MAC 365 consists of death, RRT, or persistent renal dysfunction at 1 year? This is a follow-up trial of ELAIN trial. Background for this trial: this optimal timing for initiation RRT in patient AKI is unknown. This trial look at the 1 year outcomes of patient enrolled in ELAIN trial. Major adverse kidney events at a 365 days means MAC 30. The ELAIN trial examined 90-day mortality of patients who were randomized to receive RRT within 8 hours reaching the KDIGO stage 2 or delay RRT within 12 hours of reaching the KDIGO stage 3, or if they had an absolute indication of initiation of RRT. The ELAIN trial show improved 90-day mortality early versus delay RRT is a 39 point versus 50.4, shorter duration of RRT 19 days versus 25, reduced ventilator time 125 versus 181, and reduced the hospital length of stay 51 versus 82. This trial aimed to determine if the beneficial intervention of RRT was sustained at a 1 year mark. It is known that the mortality and morbidity after receiving RRT in ICU high. For example, post-renal prolonged outcomes after kidney injury requiring dialysis in the ICU. Studies that the 4 years more than 60 of a patient have received dialysis in ICU were now dead, and more than 5% who survive requiring ongoing dialysis. The START AKI trial currently recruiting this trial is larger than ELAIN. It is aiming to the recruit 2,866 patients versus 231 in ELAIN. Comparing the early RRT versus standard care, the study includes the ICU patient with renal dysfunction who have doubling of a baseline creatinine or creatinine more than 354 millimole or urine output less than 0.5 ml per kg per hour for 12 hours. Primary outcome is 90-day mortality and independence from RRT. Designed for the study, the ELAIN trial was randomized, unblinded, single center, complete follow-up. Patients were allocated 1:1 early versus late dialysis, stratified by the hemodynamic SOPA score. For patient discharge alive at 90 days, telephone calls were made to a general practitioner, subject or family member to determine if the patient was alive, if they were requiring RRT, or if they had a persistent renal dysfunction. Defined as a 25% decline in eGFR compared with the baseline calculator of Cochrane Gold formula. In addition to relation inflammatory biomarkers collected ICU day 0 to day 3 to the MAC 365 outcome was analyzed. 1 year outcomes were available for the but one patient lost. University Hospital Munster Germany, ELAIN recruited from the August 2013 to December 2015. Population for this study inclusion must have met all of the following: acute kidney injury, KDIGO stage 3, 2, two-fold increase in serum creatinine from the baseline or urine output less than 0.5 ml per kg per hour for more than 12 hours despite optimal resuscitations, pulmonary capillary wedge pressure more than 12, cardiac index more than 2.6, MAP more than 65, and intra-abdominal pressure less than 15. Nagal more than 150. At least one of the this is a biomarker. At least one of the following conditions: severe sepsis, catecholaminerine requirement more than 0.1 microgram per kg per minute. Refractive fluid overload, worsening pulmonary edema, PF ratio less than 300 mg, fluid balance more than 10% of body weight. Development or progression of non-renal organ dysfunction, soma organ system score more than 2. Age between 18 to 19, intensive to provide full intensive care treatment for at least 3 days. Patient with a pre-existing kidney disease not requiring the RRT. Patient who had received any previous RRT. This is exclusion criteria. AKI was permanent occlusion surgical lesion of the renal artery, obstructive AKI, HUS, TTP, prior kidney transplant, hepatorenal syndrome, AIDS with CD4 count, 231 randomized and including the primary analysis. Intervention, initiation of RRT within 8 hours of confirmation of KDIGO stage 2. Deliver at 100% patient assessed and to early group. Median time of RRT was 6 hours. Initiation of RRT with 12 hours of either KDIGO stage 3. Creatinine rise 3-fold increase from the baseline or oligogram 0.3 per ml per kg per hour for 24 hours or serum creatinine more than 4 mg per ml per dl. With acute increase at least of 0.5 mg ml within 24 hours. Absolute indication of RRT: urea more than 100, potassium more than 6, magnesium more than 4, blood pH less than 7.5, acidosis, urine out production less than 1200 in 12 hours, anuria, organ edema in the presence of AKI resistant to diuretic. Treatment defined as one of the trial of furosemide. Delivered 91% assigned to delay group. Median time to RRT was 25.5 hours. Common to both groups. RRT standardized, continuous venous hemodialysis filtration. This is one of the CRRT, continuous replacement therapy. Reduction 100%, dialysate replacement fluid ratio 1:2, fluid flow 30 ml per kg, minimum 110 ml, minimum blood flow, citrate anticoagulation. RRT discontinue if renal recovery evident by both more than 400 ml urine in 24 hours without the diuretics or more than 201 1000 ml in 24 hours with the diuretics, creating clearance more than 20 ml per hour. RRT could be changed to SLADE after the 7 days if no recovery. Additional treatment, ventilation, nutrition, standardized. Follow-up 1 year post-randomization. Primary make 360B score at a 1 year. Composite of persistent renal dysfunction, dialysis, dependence and mortality. Early versus delay. 64 versus 89. Reliability index 17. Number needed to treat 5. Secondary outcome 1 year all cause mortality 50 versus 69. Increase in mortality between day 90 to 1 year. Early 39 to 50. Delay group 54 to 69. Failure to recover renal function. Early groups 29. Delay 63. Need of RRT at 1 year. Early group 7.3. Delay 11.1. Exploratory biomarker analysis 159 of 204 patients had biomarker measured on day 0 and 3 after randomization. Pro-inflammatory MIF, interleukin 6, interleukin 8 and interleukin 18, anti-inflammatory interleukin 10, TNFR1 and TNFR2. Elevated TNFR1 and TNFR2 they were higher in those who met a MEC60 endpoint. Elevation in other markers were not associated with the MEC 365 groups. Positive group. ELAIN 12-month follow-up. MEC 365, 64 versus 89. Mortality 50 versus 69. 29 renal function 29 versus 63. And dialysis 7.3 versus 11. Strength for these trials. Only one patient lost a follow-up up to 1 year. An important question is RRT in the ICU setting merely supportive or can be influence the patient-centered outcomes? Does the timing of initiation influence this? Intention to treat analysis. Those in a delay group who did not receive dialysis. 11 patients did not progress to stage 3 and 4. Stage 3 but did not get dialysis. One did not get dialysis as no machine available with analyzed in the group where the randomized single center unblinded weaknesses for the study, mainly post-surgical cohort with a high proportion of post-cardiac surgery cases, making the general liability difficult. The study is small and likely underpowered. Fragility index in the original ELAIN study was only 3. The primary outcome was not included in this trial protocol. The only 1 year outcome pre-specified in trial protocol was all-cause mortality. Other conclusion in this cohort of critical ill patient with AKI after 1 year early initiation of RRT compared with delay RRT continues to have benefit of composite outcome of mortality, dialysis dependence of renal function. The results suggest that the early RRT predominant more post-operative patient with a stage 2 AKI positive influence mortality and other patient-centered outcomes at 1 year. Renal replacement therapy does not carry cost or some risks of the patient. Some, although this encouraged me to use RRT early. I await the result of the start AKI trial, which will be invaluable in answering the important question of optimal timing of RRT. In further lecture, we can start or we discuss the start AKI trial in further study. You can stay tuned the channel. Thank you guys. Please subscribe to my channel.